Good evening. Joining us this Saturday evening, this is Dr. Ashish Prasad from the medical team of USV. Welcome to this session on navigating the future of diabetes care. Get ready to embark on this exciting journey as we navigate through the latest breakthroughs, discoveries, and insights from the ADA scientific sessions. Leading the way is our esteemed moderator, Dr. Nanditha Arun, and joining her as our eminent expert is none other than Dr. Shashank Joshi, our visionary in diabetes research and treatment. With his profound knowledge and vast experience, he's set to enlighten us with his groundbreaking perspectives. Together, our experts delve into the future of diabetes care, exploring the cutting-edge advancements, approaches, and breakthroughs, therapies that will shape the lives of millions around the world. We give a quick introduction of Dr. Nanditha Arun. I'll just share screen. I hope this is visible. Dr. Nanditha Arun is the director and consultant diabetologist at the Dr. A. Ramchandran's Diabetes Hospitals. She underwent training for research at University of Cambridge, UK, and training for diabetes at Christian Medical College, Vellore, and diploma in diabetes from Cardiff University, UK. She was conferred a fellowship by the Royal College of Physicians, FRCP, Glasgow, and fellowship by International Medical Science Academy, PIMSA. She underwent training for healthcare management at the prestigious IIM Ahmedabad. She's a member of several diabetes and medical societies and organizing member of several international conferences. She has several international publications and presentations to accredit, and she's a co-investigator of many drug trials. With this brief introduction, I hand the session to ma'am.
Thank you, Dr. Ashish. Very good evening, everyone. We bring greetings from the lovely state of California. So it's around 7:30 a.m. in the morning here. Of course, thank you, USV, for arranging this meeting this morning. I will be introducing none other than our beloved Shashank Joshi sir, who of course requires no introduction. He is an esteemed faculty in most of the international conferences, requires no introduction in most parts of the world, especially not in India. All of us know him as the celebrity doctor. The moment he walks in, he lights up the room with his presence. So sir is, of course, just briefly to introduce, he is the past Dean of Indian College of Physicians. He's been honored by the government of India with the Padma Shri. And he is also the chair of the IDF Southeast Asia, was the chair in 2019 to 22. Sir is now going to be briefing us about the latest updates from the ADA 2023, which is happening in San Diego, California. Over to you, sir.
Thank you, Nanditha, for your kind words of introduction. Am I audible?
Yes, sir, you are.
Yes, sir.
And are my slides visible?
Yes. Yes.
Okay. So, the ADA was inaugurated by their chief scientific officer and their chief CEO, Dr. Chuck and Dr. Bob Gabe. And he chaired the first session in the panel with the president of the ADA, which was Francis Collins. We all know Francis Collins is the pioneer of the Human Genome Project over the last 25 years. And this was his statement. And this opening keynote was on omomics data, which paved the way for precise research in variances within diabetes. Ultimately, what Francis Collins talked about was endotypes of diabetes or clusters of diabetes. And he said that, the thing which we are going to see in modern medicine today is all about clusters, DNA, jivas, and he, very nicely did the construction of all that. Having said that, let me now share my, slides for today. Let me see if I have them loaded up here. One sec. And as the first talk was on that, the real cutting edge talk came out was on the pathways of diabetes, and that's really the cutting edge science which I'll talk about. So it's impossible to cover everything or what was covered in ADA in a short span of duration. And Are my slides visible?
No, sir.
Okay, let me just check. Are they visible now?
Yes, sir. Yes, sir. You can see, sir.
Yeah, one sec. So as I told you, the inaugural talk was on precision medicine and Jivas, and Francis Collins gave that path. Then I will take a quick look on pathways and carbohydrates, whether we should eat less carbs. And then eventually I'll move to a very nice lively debate. So, the pathways to stop diabetes, brain on sugar, investigating the neural challenges that promote obesity and diabetes was given by Luza Blucher. And basically, we all know that food rapidly changes neural activity to control hunger. So when we eat, and fundamentally these are basic science experiments, when we eat food, then there is a lot of neural activity. And that neural activity fundamentally controls how much we eat more. And this was their seminal effort. So when we are in an obesogenic environment, so fundamentally we are all eating food, sugar or fat, and we all know that that promotes obesity and that leads to type 2 diabetes. But fundamentally, what happens between the gut and the brain? How does this dysregulation occur? How is it contributed? And does fat and sugar have similar or different effects? So we are in an obesogenic world, and we are eating a lot of carbs and sugars and fat. And they say sugar is the next tobacco. And fundamentally, this talk highlighted how the altered gut-brain communication will have a dysregulation contributing to obesity and diabetes. So if you look at high-fat diets, they selectively blunt the lipid-mediated hunger neuron inhibition. So we tend to eat more. So when we eat fried or fatty food, fundamentally what happens is the high-fat diet blunts off the hunger neuron inhibition, which is lipid-mediated. So fundamentally, as I said, that the high sugar also fundamentally selectively blunts the glucose-mediated hunger neuron inhibition. So clearly, excessive fat and sugar intake distinctly has an effect on the is it blunts off the hunger neuron inhibition, and the nutrient intake does not elevate hunger in obese mice. So when you monitor hunger neurons in the hypothalamus and the downstream activity during feeding and glucose metabolism in lean and obese mice, you can see the cellular resolution. So fundamentally, you can see that the hunger neuron outputs regulate feeding and glucose homeostasis. And this was done in very high impact papers in Cell and Nature. So one has to manipulate neurons along the gut-brain axis to prevent or reverse the effects of obesogenic diets. So if you're eating too much of fat, too much of sugar, can we manipulate specific neurons in the hypothalamus where we can prevent or reverse obesity or diabetes? So this was cutting edge. So fundamentally, they had this project which was ongoing to monitor the obesity in the gut-brain communication for cellular restoration, to manipulate this gut-brain axis and assess prevention or reversal of obesity, to look at weight regain as a major limitation in the current medical therapies and obesity-induced plasticity of gut-brain circuits which may drive it, and then understanding the various molecular and circuitry mechanisms of diabetes and obesity which will reduce stigma. And obviously, we are trying to move the needle for people living with obesity and diabetes. So this was their insights, and this is very path-breaking. A lot of path-breaking papers were presented yesterday at the ADA. They'll be presented today also and tomorrow also. Right now, as I told you, it is between 7:30 and 8 o'clock obesity. ADA will kick off again. We recently concluded a symposium on NAFLD. You may know that today, elsewhere from ADA in Europe, they have redefined the name NAFLD to MAFLD, which is metabolic associated fatty liver disease, because ultimately they have realized that liver is a metabolic organ. Now, the next part which I'm doing is something very germane to India, because I did the STAR study and we know we are a carbohydrate country. And should we curb carbs? And is moderate carb eating the best? And Carol Kirkpatrick talked about this. should we cut carbs? And the objective of that talk was how are carbohydrate restricted dietary patterns useful, effect of various carbohydrate restricted dietary patterns on cardiometabolic risk factors like weight, lipoproteins, and A1C, and then illustrate that moderating carbs in the dietary pattern is the best for cardiometabolic health and diabetes management. So clearly you can see that what is moderate carbs, what is low carbs, and what is very low carbs. Very low carbs is less than 10% of calories from carbohydrates, which is almost impossible to do. Then low carbs is 10 to 25% of calories from carbohydrates. And that is also tough. Most of us in India, we eat around 55% to 60% of carbs, and moderate carb restriction is 26 to 44% of caloric restriction from carbs. And as you know, the ICMR in-depth data, which Dr. Mohan is author, and even I am author of that paper, clearly showed that, restricting carbs and fats and eating more proteins also can be useful in the Indian situation. Much before that, Dr. Ramachandran has done similar data to produce the same. So clearly we recognize that when we are looking at a carbohydrate restricted environment versus a high carbohydrate environment, and when we look at short and long-term studies, which are RCTs, because today we are in an evidence-based era, clearly we can recognize that there are 12 RCTs which are short duration, which is 3 months, and 9 RCTs which are 6 months. So most of the weight loss which is seen in carbohydrate restricted diets up to 3 kilograms from 9 plus 12, which is almost a good amount of 21 RCTs, are all seen in short-term trials, means less than 6 months, and you get more weight loss with carbohydrate restriction. But when it goes to trials or RCTs beyond 6 months, like 12 months and 24 months, again you can see that similar weight loss between diets more than 12 months is not so much. So you can see the impact of difference is actually quite restricted. So clearly we can recognize that there is a differential there. So fundamentally what we recognize is moderate carbohydrate eating may be a solution in the modern world because it's easily practicable. And you can see here that long-term carbohydrate restriction is very difficult to maintain, especially severe restriction, which we all know. And moderate fat intake, carbohydrate intake may facilitate long-term adherence. And not only that, when we have higher carb diets compared to lower carb diets, there is a variable LDL response. We know that, in some people, the LDL will come down, especially with reduced adiposity, while sometimes with genetic susceptibility, the LDL may upregulate. So we know that it is a saturated fat, which is a key factor which increases LDL. And generally the triglycerides come down and the HDL comes up. And we know from the Indian data that India has high triglycerides, low HDL, and high LDL. So if you see 40% reduction, greatest reduction is seen in the LDL when you reduce moderate carbohydrate, and therefore moderate carbohydrate eating may be the best. So this is the lipid data, and you can very clearly see that when it is compared to LDL cholesterol with moderate carbohydrate versus low carbohydrate versus very low carbohydrate, you can clearly see that the LDL upping is very high. So there's always a risk when we restrict carbohydrates a lot. There is a 12 milligram increase with very low carbohydrate diet of LDL. It is 4.3 with low carbohydrates, but it is hardly there with moderate carbohydrates. And that's very particular for the Indian situation. So remember that when we go on severe low carb or very low carb diets, there is always a risk of increasing the LDL. Similarly, you can see, of course, with the triglycerides, the moderate carbs do drop the triglycerides, but with low and very low carbs, the triglyceride restriction is much lower. So clearly you can recognize also on the impact on A1C. So when we eat moderate carbs, the impact of A1C is 0.15%. When we eat 30% carbs, it's 0.2. When we eat 15% carbs, it's 0.4. So obviously there is a beneficial effects on all levels of carbohydrate restriction, but obviously the lower the carbohydrate restriction, the more tough it is to maintain, particularly severe restriction. Obviously it has a better impact on A1C. That is, however, clear. Now, there is some data from outcome trials, because we are looking at cardiovascular outcomes, and the Predimed and the CardioPriv trials are shown here. These are basically Mediterranean dietary trials, where you can see that in the Mediterranean diet groups with macro nutrients where there is 40% carbs, 41% total fat, and 9% saturated fat versus low fat groups, which is 44% carbs, 37% total fat, 9% SFAs. There is a 30% reduction in composite endpoint. So you can see a control diet and between the two diets, or the nuts diet or the EVOO, which is the Mediterranean diet, you can see clearly there is a drop in the primary endpoint, and this is CV outcome trials. When we look at the cardio-pre trials, again, you can see a 27% risk reduction in CV endpoints with a Mediterranean diet of a hazard ratio of 0.73, adjusted for diet, age, family history of coronary artery disease, and smoking. Clearly, you can see the curve separating out. Obviously, we also know that extremes of carbohydrate intake is increased mortality risk. So moderation is the key. If you have too less compared to moderate, and if you see the pooled hazard ratio, it is 1.2. So obviously there is an increased mortality. And if you eat too much of carbs, more than 70% compared to moderate carbs, again, the pooled hazard ratio goes to 1.23. So actually what is very insightful from this presentation given yesterday is having the right amount of carbohydrate or moderating the carbs is far more important. Having it too less or too much may be detrimental to health and longevity. So clearly the take-home message is that you need to do moderation of carbs with a lowering of A1C and triglycerides. Obviously, the A1C and triglyceride reduction is more with severe carbohydrate restriction, but the effect wanes away after 9 months or 6 months. And the very low carbohydrate intakes are difficult to maintain. And there may be a linkage with mortality in cohort studies. So clearly the recommended dietary patterns can be moderate in carbohydrate, so replacement with healthy protein foods and unsaturated fatty acids, and the strongest evidence of benefit is in the Mediterranean foods. So should we curb the carbs? Is very low carbohydrate eating the best? Well, this was the next diet, by Yancy et al. And clearly you can see that this is clearly seeing that a case for very low carb eating will improve glycemia, a case for very low carb eating not increasing cardiovascular risk. So let's look at this nice, we know that from 1923, before insulin was discovered, Jocelyn had a diet and Ellen's had a diet. And formerly diabetes was managed by Jocelyn diet or Ellen's diet before the discovery of insulin. And dietary treatment was the first important concept. And carbohydrates taken in fruits are of no use to the body and must be removed by the kidneys. And therefore, the polydipsia, polyuria, pruritus, renal disease was discovered by Elliot Jocelyn. So 1923 carbohydrate in the Jocelyn diabetic diet was 40, you can see here, 15 grams of carbs, 75 grams of protein, 150 grams of fat, 10 grams of alcohol. So strict diet, meat, poultry, game, fish, clear soup, gelatin, eggs, butter, olive oil, coffee, and tea. And this was written in Osler's textbook of medicine in 1923. And if you look at the diet, 24-hour glucose insulin levels in type 2 diabetes, the A1C drops down with low carb diet by around from 7.3 to 6.8% in 14 days. So there are different models, and this is the carbohydrate insulin model. So the dietary carb, which is sugar or starch, raises the glucose or insulin. The carb restricted diet it reduces the diet contribution from glucose, and the insulin is a potent stimulator of lipogenesis and potent inhibitor of lipolysis. So fat storage and fat burning, and lower insulin levels or dose leads to burning of the stored fat, raising ketones, and therefore some people call it a ketotic diet, lowering the body weight. So this was described, in the classical Ludwig paper in American Journal of Clinical Nutrition in 2021. So clearly, if you see glucose insulin response and the area under the curves from the Ludwig model, from low GI, medium GI, and high GI, clearly we recognize the insulin glucose peaks are different for the low GI diet, medium GI diet, and high GI diet. And if you look at systematic review of all diabetes papers of percentage of change of A1C by dietary carbohydrates, and if you look at 13 trials which met the criteria with moderate carbohydrate restriction, like less than 45% carbohydrate from 2 to 26 weeks of duration, this is the scatter plot which we see, which was published long time back. So if you do a network meta-analysis comparing dietary effects on glucose in type 2 diabetes, totally there are approximately 56 trials, 4,937 participants comparing 9 diets. And if you see each node, whether it is a low fat but vegetarian mode, Mediterranean mode, high protein mode, moderate carbohydrate mode, low carbohydrate mode, control, low glycemic index stroke load mode. And if you look at the thickness of the lines is proportional to the number of studies in each comparison. And of course, then we have the paleophilic diet also. So thicker the line, the more is the data. And you can see in moderate carbs, there is a very strong line. So is for high protein, low carb, control, and low glycemic index. In the vegetarian mode and the paleophilic mode, the line is much lesser. So from A1C perspective, the low carbohydrate diet was ranked the best dietary approach, with Sukura being 84%, followed by Mediterranean diet 80%, and the Paleolithic diet 76% compared to control diet. So obviously, should we curb the carbs? Well, if you look at the meta-analysis of association of saturated fats with cardiovascular disease, that's pretty well known. And very low carb diet is superior to low fat diet in improving metabolic syndrome. So you can see all the greens of metabolic syndrome are seen, and you can clearly see that the saturated fat is lower even though the dietary intake was higher. So clearly you can see that when it comes to a patient case, clearly you can see 67-year-old person with diabetes, dyslipidemia and hypertension, you can actually discontinue many of these medications when you curb the carbs. So clearly low carbohydrate nutritional approach in pre-diabetes and diabetes is a big thing now. And you can see that there is a rapid reduction in glucose and insulin levels, lower carbohydrate intake and lower blood glucose trends in patients with diabetes, very low carbohydrate eating patterns, low medication requirements, blood pressure decreases, serum HDL and triglycerides decrease, and LDL doesn't typically increase, and small dense LDL decreases. Now let me move from dietary perspective and genomic perspective and pathways of diabetes into combination. Are two better than one? And is initial combination therapy in type 2 diabetes, a great option? Because, and there was a debate of pros and cons between Ralph DiFranzo and David Nathan, and it's very pertinent to India. We know Ralph DiFranzo is very popular in India. Are 2 or 3 better than one as a combination therapy? And clearly this was the mirror on the wall. What is the best therapy for all? And Professor DiFranzo always believes in combination therapy. And he believes that it depends on the individual anti-hyperglycemic agent, the insulin resistance and beta cell failure, and each agent should have the extra cardiovascular protection, kidney protection, and liver protection. And we clearly recognize that, from various cohorts, the tighter the glucose control, the better it is. And this data has been very clearly recognized over a period of time. We also know that most agents fail because of the complex pathophysiology of type 2 diabetes. And the old therapy of, one drug, then second drug and third drug is a treat to fail approach. And there's a lot of physician inertia which delays initiating therapy. And we need to overcome both patient and physician inertia. Of course, Professor DiFranzo described his famous octet. We all know the octet. And clearly we know that the treatment of type 2 diabetes should be combining drugs to correct those multiple pathophysiological defects. It must be based on the known pathogenic abnormalities, not just an A1C reduction. And we must hit early, because if you start them early in the natural history of type 2 diabetes, then the progression to beta cell failure is prevented. So obviously, we need to recognize that we need to overcome this treat to fail approach. And we saw this old approach when we used to have glibenclamide and metformin. There was a rapid upswing and failure of treatment. And you can see that in the GREAT trial, which was an excellent trial, which looked at A1C levels in the first 4 years, you can see that glimepiride, sitagliptin, liraglutide, and glargine, almost the metformin failure was clearly recognized. So the idea is to hit early. And if you look at progression of retinopathy and albuminuria of 8 years follow-up DCCT, with if you do intensive glucose control, you can see the retinopathy progression or new clinical albuminuria is clearly recognized. So DiFranzo has his own algorithm. It utilizes the cardiorenal metabolic drugs in combination. He believes that GLP-1, SGLT2, pioglitazone, and metformin are the way to go in modern day diabetes management. And that's what he feels. There should be a GLP-1, there should be a pio, and that's what he feels. The TZDs work on all these pathways. The GLP-1s work on all these pathways. The SGLT2 inhibitors work on all these pathways. And if you combine this combo of A1C, weight loss, renal cardioprotection, liver protection, the pentad which he has put out, A1C, weight, CKD, fatty liver, and CVD, that's the way to go. And he presented his data of duration 8, which was basically a GLP-1 with the DAPA versus, again, GLP-1 or DAPA alone. And you can see the combination of GLP-1 and DAPA had a more robust drop of A1C. And similarly, efficacy over 2 years also was better. So there is sustainability and durability of the drug. And you can see the durability also if you look at metformin vildagliptin compared to metformin added after vildagliptin, which was demonstrated in the Verify trial, also showed the same. So obviously, it's important to recognize that fact. We all know the EDIC trial, the efficacy and durability of initial combination therapy in type 2 diabetes in drug-naive new onset type 2 diabetic patients, randomly assigned initially for a combination therapy of GLP-1 pioglitazone metformin versus sequential addition of metformin, glipizide and glargine. And the primary endpoint after 3 years with triple therapy was less than 6.5 after 3 years. And clearly difference showed that if you use a triple therapy, the A1C is 6.1, almost in remission mode compared to the 6.9 in conventional therapy. And if you look at the Kaplan-Meier plot of the treatment failure of EDIC, you can see that it is much higher, in the conventional group compared to the triple therapy group. And also the triple therapy will preserve the beta cells better and improve the insulin action better. And also will have a more beneficial effect on the carotid media intima thickness and clearly done. Also, if you look at the Qatar study, which was a research design with poorly controlled patients of type 2 diabetes, which you often see with sulfonylurea and metformin, a GLP-1 with pioglitazone was added compared to basal bolus. And you can very clearly see again, when you add GLP-1 with pio compared to insulin, you can see very clearly that the combination therapy performs better compared to insulin therapy alone. So obviously, type 2 diabetes is a progressive disease. And we all know that we need to maintain glucose targets. And if you use a combination therapy early, this is initial data to support that faster glucose control, longer durability of glycemic effect is documented. So Dr. DiFranco clearly believes in the combination therapy. David Nathan, who wrote the former ADA ESD guidelines, felt, no, you don't need to give this. And, he said history of sequential therapy was fail safe. He had a well-validated core therapies versus less validated core therapies. And he felt that if you give good lifestyle with metformin and treat them to target, it's a valid option. And then use insulin. While it's a less valid option to use a DPP-4 or SGLT2 inhibitor and so on and so forth. And, he is a strong believer of the original guidelines. And he says metformin, because of the high efficacy, is used in monotherapy, is traditionally recommended as the first-line glucose therapy. And combination therapy of stepwise additions, advantages are to look at the pros and cons of each of them. And if you look at standards of care, we know the clutter plot which is available, and I don't want to go into details of that. So, in the debate, he said, I will not argue against the use of early or initial combination therapy when there are coexisting comorbidities. Because if there are coexisting comorbidities, the merit use is demonstrably effective medications may be useful. But he rather argued that sequential therapy justifiable as an initial approach in treatment of most patients with type 2 diabetes, and initial monotherapy with sequential addition of medications as needed rather than initial combination therapy. He said if there is comorbidities, probably use combination. If there are no comorbidities, don't use a combination. And this was his classic debate slide, which was all over the Twitter, that traditional sequential combination enables determination of efficacy, adding individual medications. You can assess side effect of each individual therapy. It does promote individualization. It is more cost effective, and there's a lots of data to support. While the early combination therapy, it actually clutters the use and benefits of individual drugs, confuses side effects, limits the ability to titrate and individualize, is expensive with modest advantages, and trial data is more limited. He also looked at potency of drugs, and he felt insulin and metformin are the most potent anti-diabetic drugs. Every other drug apart from sulfonylurea, metformin, and insulin, are less potent. Maybe GLP-1s come there, but all other drugs are not there at par at all. And then he looked at all the trials and searched all the clinical trials of initial combination versus monotherapy or sequential versus combination regimens. And when he did that search, he got 81 results, 46 were off topic. There were 31 possibilities, 19 were observational, were pilot or reviews or meta-analysis. And he removed all of that clutter from the evidence-based era. And he ultimately was able to filter out 19 RCTs. From the 19 RCTs, 16 initial combination versus monotherapy and 3 combination versus sequential therapy. And you can see here very clearly that all of them had some backbones, but the most commonly studied drug in glucose-lowering medications included in such studies have been gliptins. And not surprisingly, they are the least potent glucose-lowering medications. And then but of course, this is in the Caucasian population. We need to understand that in the Indian population, it is very different. And these are all the gliptin studies, the Verify, the Rosenstock study of allogliptin pio, the MET-SAXA, MET-Velda, MET-Tallo, and so on and so forth. And if you look at all the clinical trials, which combine the combination therapy versus monotherapy, when compared to DPP-4 monotherapy, which is among the weakest glucose-lowering medications, combination therapy with DPP-4 reduced A1C only by 0.5 to 0.9 when compared to more potent single agents. And these trials were only over 16 to 26 weeks. And clearly, he was able to make his point that the risk of short-term studies in chronic disease, like the grade, clearly shows that it may not be worthwhile. And we need to have none of the studies which were sequential therapy, specifically if monotherapy or combination therapy failed to achieve metabolic goals and were not systematically. Of course, we have the Verify data, and Verify demonstrated superiority of initial combination gliptin with metformin compared to metformin alone, and a small effect of the various data which were seen in the same. But the EDICT trial was a small exploratory study. The new onset diabetes was only 5 years, no medications at baseline, and the initial combination was PIO, MET, and GLP-1, and the outcomes of weight, hypoglycemia, and cost were not studied. And then he went on to criticize Dr. DiFranzo's study on the data point that it's 58 versus 68% after 24 months. And then, he said that the cost was, additional cost of EDICT was almost for 1.5 million patients for new onset diabetes was 22 billion US dollars. So he stuck to his point. He didn't give up his point. And he says one study that explored combination versus sequential therapy showed clinically trivial difference on A1C, mixed bag of other benefits, and enormous added cost. So he said that well-powered, acceptable duration studies are needed so that we can adopt better initial and combination therapy. And he laid his debate there. And he says that we need to address the more compelling issues in type 2 diabetes, which is not the degree to which we have to have initial or sequential therapy, which may be beneficial. So, those were some of the highlights which I wanted to point out. Obviously, it's been, very robust ADA. There was some exciting data from the SURMOUNT trial. And from the SURMOUNT trial, we saw that there was these dual agents, which like tirzepatide, which may be very effective. But mind you, my caveat to the SURMOUNT trial or, oral GLP-1 agent, which was presented at the, and it's also published in New England Journal of India Medicine. There was an HSK compound, which was also published from East Asia, which is once in 2 weeks gliptin. So, in the therapy world, what was new in ADA yesterday was, of course, the compelling data of weight loss from the SURMOUNT data. Second one was the once in 2 weeks gliptin, which came up with the modest data. And then there was other GLP-1, GIP agents or dual triple agents with some compelling weight loss, including an oral GLP-1 published in New England Journal. And these data are all, original data, a lot of excitement. But remember, when you lose a lot of fat and lose a lot of weight, you also lose a lot of muscle mass. And when we lose muscle mass with some of these agents, then, Indians are sarcopenic. And because we are sarcopenic and when we lose muscle mass, what happens is that you will actually live shorter. So when we are recommending some of these novel agents for weight loss, we need to also be mindful that when you lose weight, you lose a lot of muscle mass. And what is not clear right now is the degree of muscle mass which is lost with proportionate water and fat loss with some of these compelling agents. They still need to go through the pharmacovigilance mode of scrutiny and safety, because the weight loss medications always have been wedded with a lot of side effects. So though the hype and excitement is great and the data looks very compelling, it's still early days to make us a robust recommendation in some of these novel agents. But it's exciting. Today at ADA, there is a lot of exciting data coming up. There'll be some cutting edge presentations, some excellent debates, some posters, and some very nice oral presentations which will come up in the course of the day. Of course, the technology has invaded the ADA in a big way. There are some very nice papers coming in stem cell research in type 1 diabetes. There is some excellent data in closing the loop. And there are also some exciting data where the CGM will be integrated with the smartphone watches. That data is coming up. Also, the CGM is moving from CGM to CKM, which means they will be able to monitor both glucose and ketone bodies together. So those are some of the exciting things coming up for the day. I'm thankful to my friends from USV for allowing me to speak here. And I'm sure Nanditha will be able to do a good summary of the same. And you'd have to excuse me because I have to go for another presentation. But it is wonderful to see some cutting edge science being debated and deliberated at ADA. Remember, we need to be very cautious that all this data presented at ADA is predominantly for a American population. We need to adapt it to the Indian population. We should be very mindful of our clusters and phenotype, and we need to generate Indian evidence. But yes, this is very insightful. It's the world's largest diabetes meeting. Some very high-end cutting-edge science is presented here. And I'm certain that this few snippets which I picked up, you have been wiser, because we are committed for a single goal, which is to improve the lives of people living with diabetes. Thank you.
Thank you so much, sir. It was a pleasure, of course, as always. Dr. Ashish, would you like me to take over, or how would you like to go about it?
Yes, sir. I think there are some questions that we have got from the audience. We can take those questions.
Okay.
Is it okay with you? I'll just read out.
Sure,
Some
of
of them
course,
are based on this one, not exactly on the AD updates. I'll just read out a few.
Okay, sure. So would you like to read out the questions?
Yes, sir. I'm just reading it out. One question is from Dr. Chandramohan. He's asking which insulin is better in patients with renal and hepatic impairment?
Which insulin is better?
Which type of insulin?
Right. So, I think patients with in general, patients with comorbidities, whether it is hepatic or renal impairment, one thing to keep in mind is that these are patients with high risk population, and most important factor is that they're probably at increased risk of hypoglycemia for various factors. In patients with chronic kidney disease, of course, we all know that because of the impaired renal clearance of drugs, there is an increased risk of hypoglycemia. Of course, beyond that, the uremia and the sarcopenia that coexists with CKD, there is an increased risk of hypoglycemia again. So because of the unpredictable absorption of drugs, including oral agents, the safer choice would always be insulin in both patients with hepatic and renal impairment. That's the first thing to keep in mind. Now, which insulin? Of course, the better choice would always be an insulin analog, because analogs do have a lower risk of hypoglycemia as compared to the traditional insulins. Now, among the analogs, you have various options available. If you look at it from the most scientific point of view, the regime that would obviously give you a lot of flexibility and the options for you to the sort of fine-tune the dosage of insulin according to the patient requirement would be a basal bolus regime. So among the basal insulins, among the analogs, of course, you have degludec and you have glargine, which are available. You also, of course, have the glargine U300, which is longer acting. Among the shorter acting insulins, you have ultra short acting, which is Fias, which is available with Novo Nordisk, and then you have most of the other short acting insulins as well, which have a lower risk of hypoglycemia. Beyond all this, you also have the combinations like IDEG-ASP, which is a very good option for patients in whom the compliance to therapy, like for example, patients in whom the basal bolus regime becomes challenging. You could always consider IDEG-ASP, which gives you both flexibility, gives you the option of a lower risk of hypoglycemia, and patient satisfaction and adherence would also probably be better. So to summarize the answer to this question, I think the insulin analogs are obviously the way to go, especially in patients with comorbidities, like your question, doctor, where it is patients with hepatic and renal impairment. The best option would be to choose insulin analog, which would reduce your risk of hypoglycemia, keeping in mind, of course, the economic status of the patient as well.
Thank you, ma'am. Ma'am, coming back to the topic which Dr. Joshi covered in his presentation on the curbing the carbohydrates. So for those audience who missed out on that part, and just to summarize that, if you can share your personal thoughts on that, should we go with the very low carbohydrate intake or the moderate intake? So just for the benefit of those audiences.
Of course. So I think like Shashank sir was summarizing during his talk, he has also, to his credit, the STARCH trial, in which he's shown that majority of our diet, all pan India, is carbohydrate centric. Now, of course, there are a lot of fat diets available, including the low carb diet, which has gained a lot of limelight over the past decade or so. But I think to be realistic about our approach, when it comes to clinical practice and actually translating this into the clinic, it's probably not very practical to impose this on most of our patients, because it's something that patients cannot really even begin to understand. When you tell them low carb, beyond this, most of our patients are also vegetarian. So when we tell them low carb and when we say high and we replace that with protein, the sources of protein in the Indian vegetarian diet is also very challenging. So, but of course, from what the data that has been presented at the ADA, like sir was saying, we do have to keep in mind this is all more applicable to the Caucasians and may not be very practical, like I said, to the Indian context. But from the data that they've presented, it's quite evident that yes, lower carbs and reducing carbs is beneficial. The benefit is in terms of not just reduction in HbA1c, but also improvements in cardiovascular risk factors as well. And beyond all this, of course, one thing that sir also brought to light was that moderation is key. So extreme carbohydrate restriction can also be detrimental. He also showed us a study in which subjects in whom there was extreme carb restriction, there was actually increased mortality. So I think to summarize this, like I said, it's important to note that moderation is key, and probably if we can try to make our patients understand that a high carbohydrate diet, or the carbohydrate centric diet, what we usually follow in our Indian context, which is about more than 50 to 60% of carbohydrate, if we can reduce that to around 30 to 40 and increase protein intake, increase the intake of vegetables and fiber, then that would probably be the best way to go about it. But like I said, I think moderation and balance would be key for improving outcomes in our patients.
Right, ma'am. Thank you for summarizing, ma'am. Also, Dr. Joshi mentioned towards the end that there was a presentation on one molecule, which is once in 2 weeks DPP-4 inhibitor. So on that topic, ma'am, also I remember like many years back, there were at least two DPP-4 inhibitors which were once weekly, but which never really got into mainstream clinical practice. They were mainly approved in the Southeast Asia. So what is your take on the future of these kind of inhibitors, which are like once a week or once in 2 weeks? Do you think they'll be able to cater to any need in the diabetes management?
Well, cater to the need, absolutely, because as we all know, diabetes is a chronic disorder in which patients do struggle. One of the biggest challenges that patients do face is adherence to prescriptions. And we know that when we see patients in our clinic every day, most of them do confess that they miss their medication due to various reasons, because yes, life gets in the way. So yes, if there is a drug that can improve compliance, and if it's going to be once in 2 weeks or once fortnightly, yes, that will probably definitely help in improving patient compliance. But I think this is very initial for us to sort of conclude anything from this. So we'll have to wait and watch to see further results from the trials.
Yes, ma'am. Also, I think there was a detailed discussion on the approach of combination therapy, whether it should start early or maybe should be first stepwise. So, in your practice, what are the factors that you decide that when should we be using right from the beginning, there's the combination therapy, or when should we do a stepwise? So, what are the factors that we should keep in mind when deciding this?
Right. So again, here, I think one of the most important points to keep in mind is that all the data that is being presented there is all applicable to the Caucasians, number one. Number two, we also have to keep in mind that we, as the Indian phenotype, the so-called thin fat Indian and the Indian phenotype is very different. We have, of course, many factors which contribute to the high burden of type 2 diabetes. And there are certain peculiarities when it comes to the Indian phenotype of type 2 diabetes. One being that we have a younger age of onset, and we have higher insulin resistance for any given BMI. We have higher visceral adiposity, and we also have lower beta cell function to even start off with. And the beta cell decline is much more rapid as compared to that of the Caucasian population. So with that in mind, we do have to be cautious when we sort of completely blindly follow the guidelines that and the discussions at these conferences. So what we need to keep in mind is, from the Indian context, or when we see patients in our clinic, the most important point is to individualize therapy. And we also have to understand that type 2 diabetes, yes, is a multifactorial disease. It is not just one pathophysiological feature. It is not just insulin resistance, or not simply not just the beta cells which are contributing to the hyperglycemia, but multiple pathophysiological pathways, including the alpha cell hyperglucagonemia, the insulin deficiency, the insulin resistance, and then we also have, of course, the increased renal threshold, the increased reabsorption of glucose at the kidneys. So all these which are contributing, the impaired incretin pathway, all these are contributing to hyperglycemia. So the treat to failure approach, or the stepwise approach as we call it, which Dr. Nathan had discussed in his debate, may not practically be the best approach, because we all know that with the stepwise approach and with the treat to failure approach, we are exposing our patients to that many days or that many months or even that many years of hyperglycemia, and driving them towards complications. So it's literally waiting for the blood sugar to go up until we take action. And that is typically what we call treatment inertia. So why wait when, like Sir was saying, when we can hit hard and hit early, and we know for a fact that early glycemic control is key to reducing the risk of complications in our patients. That being said, we are also in an era now where we have at our disposal agents which target all these multiple pathophysiological features. Just simply about 10-15 years ago or 2 decades ago, we only had, after metformin, we had the sulfonylureas, and then failure of which we had insulin. But that's not the case today. We, at our credit, do, we have at our disposal agents that work not just on the beta cells, agents like the DPP4 inhibitors, which work also on the alpha cell hyperglucagonemia. We have agents like the SGLT2 inhibitors, which work on the renal glucosuria. We have the GLP-1 analogs. We have all these agents which are available, and GLP-1 analogs, oral agents, also make it easier for prescription. So when we have agents which offer benefit beyond glycemic control, these are agents, the newer agents, which have also proven cardio-renal metabolic benefits, and also reducing the risk of complications in our patients. So when we have at our disposal drugs that help in reducing blood glucose, lower risk of hypoglycemia, improving outcomes in terms of body weight reduction, fat reduction, reducing the risk of complications, and improving adherence as well, why not hit hard, hit early, and improve outcomes in our patients? So I think the key here is to individualize therapy, and the treatment to failure option probably may not be the best way to go.
So you're leaning on the side of Dr. Defonso.
Absolutely.
So coming back to the topic of diet, there's a question from Dr. Manish Bhatia from Meerut. He wants to know what should be the dietary advice for a lean and thin, weak diabetes patient with hypertension.
Lean patients with diabetes and hypertension.
Hypo.
Right. Now, when we say lean, again, like I'd said earlier, lean may be in terms of BMI, but it may not be in terms of metabolic obesity. So by definition, when we say lean, it does not, a person with a lean BMI may actually have more of abdominal visceral adiposity, which again translates to high cardiovascular risk. So, but yes, a sarcopenic patient with diabetes and hypertension, I think the best option would be to initiate insulin as soon as possible. We cannot underestimate the importance of insulin and early insulinization in our patients. And as I said earlier, most of our patients are, majority of our patients, and we as Indians are insulinopenic. Early insulinization and early initiation of insulin would be, intensification with insulin would be key to achieve targets and reduce the risk of complications. Of course, screening for other complications like retinopathy and annual screening for progression of nephropathy would also be extremely important. Cessation of smoking, lifestyle modification, salt restriction. Of course, we cannot forget the importance of lifestyle changes as well in our patients. This would probably be the best approach in such patients.
Right. There's a question from Dr. Surinder Gupta. He is asking a very futuristic question. His question is, what will be the role of artificial intelligence in decision making for treatment of diabetes? The role of artificial intelligence in the treatment.
Artificial intelligence, right? So AI is definitely taking over, and it's changing the lives of patients in many ways. AI is there in both diagnostics as well as therapeutics. When we look at diagnostics, the role of AI is a huge hit, in fact, in screening for retinopathy, where we have artificial intelligence in staging of retinopathy and diagnosing the stage of retinopathy. So it's almost replacing the role of a specialist in the field of diabetic retinopathy. Beyond that, of course, you have AI. When it comes to therapeutics, we have the insulin pumps, the newer pumps, which are the 780G with Medtronics, which is also a fantastic device that is literally changing the lives of patients, in which you have artificial intelligence integrated into CSI, which literally detects the trend of blood glucose, detects a hypoglycemia even before the onset, and this is the first time I think we're now able to achieve a target HbA1c without the risk of hypoglycemia in patients with type 1 diabetes. Of course, AI may in the future also have a role in therapeutics in terms of treatment tools, in helping us with electronic medical records. So a lot of areas in which AI is applicable, but it is the future of diabetes care, absolutely.
Thank you, ma'am. There's a question from Dr. Sanju Haldar on pre-diabetes. His question is that a hypertensive 53-year-old lady who remains in the pre-diabetes range for more than 2 years, should we give her medication or should we wait for the HbA1c to rise in the HbA1c in the diabetes range?
Hypertensive, is it? Was that
she has hypertensive and she has pre-diabetes also.
Right. And she's remaining pre-diabetic for 2 years.
Yes, ma'am.
And what is the question? Should we
start any medication or should we wait for it come to actual frank diabetes? I mean, about 6.5.
Right. Well, so I think there is no right or wrong here. It all, again, it boils down to individualizing therapy. So if the patient is maintaining good lifestyle and without complications, without nephropathy, no retinopathy and cardiovascular risk, with lower cardiovascular risk, then yes, you could maintain with just lifestyle modification. But if this patient is, for example, has other comorbidities, or if the patient is obese and has high cardiovascular risk, you could consider initiating metformin, because now metformin has also been approved for prediabetes. Of course, drugs like the GLP-1s and SGLT2 inhibitors would have a role in weight loss, but is of course not yet recommended and not yet in the guidelines for patients with prediabetes as yet.
Thank you, ma'am, for summarizing all the questions so well. Any last thoughts, ma'am, on the whole topic of the advancements in diabetes? After this, we can close.
Sure. So I think it was a wonderful talk by Dr. Shashank sir, and it was very nicely summarized. So I think the take-home message would be, number one, hit hard and hit early. We need to be more proactive with treating patients with type 2 diabetes. Like I said, treatment to failure may not be the best option, especially in our patients who are insulinopenic, have higher insulin resistance, and we do have a huge burden of type 2 diabetes. We have younger ages of onset. So we do need to be more intensive in our approach to patients to achieve good targets and reduce the risk of complications. Of course, we also discussed the carbohydrate restriction in our patients. And again, here we need to be more practical in our approach. It is, of course, quite evident that yes, reducing carbs does have its benefit, but we also have to be aware about the fact that it may not be something that is sustainable for many of our patients. So keeping that in mind, advising patients with something that may be practically possible, which will improve adherence and improve outcomes, will be the best way to go about it. And yeah, I think that summarizes it as such.
Thank you, ma'am. Thank you all doctors for being part of the session on navigating the future of diabetes care. We extend our deepest gratitude to Dr. Nanditha Arun for excellent moderation and Dr. Shashank Joshi for sharing his profound knowledge. Your commitment has been invaluable. Together, let us continue shaping the future of diabetes care. Thank you. Good night. See you again on Monday. Bye.
Thank you. Thank you so much. Thank you.